All right, let's get right into it. Today, we're jumping into the hot seat of a surgical viva exam. Think of it as a simulation. I'll be playing both the examiner and the candidate, walking you through a classic case, small bowel obstruction. The whole idea here is to show you how to build a rock-solid answer, from the moment the patient hits the door all the way to their long-term follow-up.
Okay, so you're in the exam room. The examiner leans forward and says, a 65-year-old male presents with 8 hours of severe, sudden abdominal pain. What is your approach? Just like that. It's short, it's open-ended, and you know the clock is ticking. Believe me, how you start your answer in these first few seconds is absolutely critical.
And right here is the first golden rule, the one thing that can make or break your entire performance. Before you even start thinking about a diagnosis, you have to prove you're a safe doctor. That means the very first words out of your mouth should be about patient safety, resuscitation in the ABCs. That's airway, breathing, and circulation. It's non-negotiable. So, as the candidate, I'd take a breath and begin calmly. Thank you. My approach will be systematic. I'll start with an immediate ABC assessment and resuscitation as needed. Once the patient is stable, I'll move on to a detailed history and physical exam to build my differential diagnosis. See? Saying that right up front tells the examiner you have a clear, safe, and logical game plan.
Next, I dive into the history. I talk them through my structure, starting with a deep dive on the pain itself. Then, I'd move to associated symptoms. Is he vomiting? Has he stopped passing gas or stool? A huge one is asking about any previous abdominal surgeries. That's a massive red flag for adhesions. And finally, given his age and the sudden pain, I'd be thinking about risk factors for mesenteric ischemia, where the bowel's blood supply gets cut off. That's a can't-miss diagnosis.
Then I'd say, following the history, I'd perform a full physical examination. I'd start from the end of the bed. What's his general appearance? What are his vitals? Is he in shock? Then I'd do a very focused abdominal exam, looking for swelling, listening for bowel sounds, and gently feeling for any tenderness or rigidity, those signs of peritonism. This methodical approach is exactly what they want to hear.
Okay, so with all that initial information gathered, it's time to put the pieces together. I'd form a differential diagnosis and then explain exactly what tests I need to figure this out.
So for a 65-year-old with this story, what's running through my head? Number one on my list, the most dangerous thing, has to be acute mesenteric ischemia. It's a true surgical emergency. But I'd also be thinking about a bad bowel obstruction, a perforated ulcer, or even something medical like pancreatitis or a heart attack, which can sometimes present with abdominal pain. Listing these shows you're thinking broadly.
So how do we narrow it down? I'd say I need urgent blood work, and the key one I'm looking for is a serum lactate. A high lactate is a major warning sign for dying bowel, because it means the tissue isn't getting enough oxygen. But really, the definitive test, the one that's going to give us the answer, is an urgent CT scan of the abdomen and pelvis with IV contrast. That lets us see the bowel and its blood supply directly.
Now, at this point in the viva, the examiner is probably going to give me more info. They'll say, okay, the CT scan confirms ischemic small bowel. So my answer has to pivot right away to the operative plan.
My response would be decisive. Okay, with confirmed ischemic bowel, this patient needs an urgent exploratory laparotomy. The goal is simple. We need to go in, remove all the non-viable bowel, and then, if it's safe, put things back together.
And here's the first critical step inside the operating room, dividing the mesentery. That's the sheet of tissue that carries the blood supply to the intestine. You have to be incredibly precise here, finding the clear line between the healthy pink bowel and the dead, dark bowel. Then you carefully tie off the blood vessels going only to the part you're removing. Mess this up, and you could damage the blood supply to the good bowel, which would be a total disaster. And here is another huge exam point. After you've cut out the bad section, you have to join the two healthy ends back together. That's called an anastomosis. But before you do that, you have to make 100% sure the bowel is oriented correctly. If you accidentally twist the mesentery, you've just choked off the blood supply to your brand new connection. It's going to leak, and the patient is going to get incredibly sick. It's a classic pitfall.
So I would then clearly talk through the steps. I'd say I would perform a side-to-side stapled anastomosis. I'd bring the two ends of the bowel next to each other, make a small hole in each, insert the stapler, and fire it. Then I'd carefully check the staple line for any bleeding, close up the opening we used for the stapler, and finally, I'd close the defect in the mesentery to stop a future internal hernia.
And this is basically what it looks like after the stapler has done its job. It creates this nice wide connection between the two pieces of bowel.
After this, it's just a matter of closing that last hole and making sure everything is sitting nicely with no tension and a great blood supply. Now, to really impress the examiner, I'd also bring up an alternative. I'd say, "Sir, if the patient was very unstable or if I wasn't totally sure about the health of the remaining bowel, it would be too risky to join it back together right away. In that case, I would resect the dead bowel and bring the healthy end out to the skin as a stoma. We can always come back and reconnect it later when the patient is stronger." But listen, a winning answer doesn't stop when you put in the last stitch. To really ace this, you have to show that you're thinking about the patient's entire journey. So you've got to transition smoothly into talking about postoperative care.
So I'd lay out my plan for the immediate post-op period. Keeping the patient from eating at first, managing their fluids, controlling pain, and preventing blood clots. Then I talk about what needs to happen before they can go home. We need them eating, we need their pain managed, and if they have a new stoma, it's absolutely crucial that they've seen a stoma nurse and feel comfortable taking care of it.
And the care doesn't stop at the hospital door. I'd say I would plan to see the patient back in my clinic about 2 weeks after they go home. In that visit, I'd check on how they're recovering, take a look at the wound, and most importantly, we'd go over the final pathology report from the bowel we removed to confirm exactly what caused the problem. Okay, let's zoom out of the simulation for a moment. We've just gone through a really comprehensive answer to a tough surgical case. So what are the big takeaways? What are the principles that make this a pass instead of a fail? First and foremost, structure is everything. When you break down the problem into assessment, diagnosis, management, and follow-up, you're creating a logical roadmap. It shows the examiner your thinking is organized, it's safe, and it's repeatable, even when you're under a lot of pressure. Second, you have to know the details of the key operations. Being able to confidently talk through the critical steps of a bowel resection and anastomosis, and even pointing out the potential mistakes like twisting the mesentery, shows you have a much deeper understanding than someone who just memorized a textbook. And finally, always think about the patient's whole journey. When you talk about post-op care, discharge planning, and clinic follow-up, you're showing maturity. It proves you're not just a technician who can do an operation. You're a clinician who's responsible for the patient's total recovery.
So I'll leave you with one last question, the kind an examiner might toss in at the end to really push you. What if your patient comes back in 4 months with a new problem related to the surgery? A blockage where you made the connection? A hernia? Thinking about those long-term possibilities and how you'd handle them, well, that's the next level of preparation.